So today, in this short session, we are going to be covering the different aspects of surface ablation, primarily from the purpose of understanding where it can be a good alternative for LASIK surgery, and also to look at some of the outcomes of surface ablation that we've seen over the last several years. So the sequence of what we'll be covering today will be the types of surface ablations, the different varieties of surface ablations. We're also going to be looking at how you select an appropriate patient and what patients to choose and whom not to choose. Then we probably will be comparing LASIK and surface ablation, and I'll be using PRK as a surrogate for surface ablation throughout most of my presentation. A little bit about topo-guided PRK or surface ablation and why it potentially could be better than LASIK surgery. And finally, to end, we will explore doing surface ablation in high myopes. So for those of you who are familiar with surface ablation, there are several varieties of surface ablation. The first and probably the one with the longest history is PRK, but then the variants of surface ablation are LASIK or laser assisted subepithelial keratomileusis, which is basically a different method of doing surface ablation, which we'll see in the next couple of slides. And then you have PRK with mitomycin C, photorefractive keratectomy with mitomycin C, and then you have epi-LASIK. The difference between these three we'll cover in the next three slides. But basically, all of these surgeries are just about the same from the perspective of outcomes. So how PRK is done is by removing the epithelium on the surface of the cornea using a number of methods, a brush or alcohol or even topical anesthetics. Doing the surface ablation using the laser and then leaving the corneal surface bare with a bandage contact lens on the surface. The difference between PRK and LASIK is in LASIK, the epithelium is removed or loosened using alcohol. It's rolled to a side, and once the ablation is done, is reposited back in place to act as a biological bandage contact lens. The third variant, or epi-LASIK, is also very similar, but the epithelial flap is created using a microkeratome called an epikeratome or an epimicrokeratome. So the difference between the three of these procedures is potentially in their terminology, but like I said before, there is really no difference in the outcome from the perspective of haze, from the perspective of accuracy, and from the perspective of healing time. There have been some reports about LASIK and epi-LASIK causing a little shorter duration of post-operative pain, but this doesn't seem to be significant, at least in published literature. So how does surface ablation compare with LASIK? Surface ablation, as all of you know, is done after the epithelium is removed, whereas LASIK, the ablation is done on the stroma below the surface. Well, to actually look at the indications for surface ablation, people always believe that there are a certain subset of patients who would be ideal for surface ablation. And these would be patients who have borderline dry eyes, where you do not want to have epithelial healing problems with your flap, where you have a poor ocular surface, and where you have anterior stromal scars, which might cause a problem with creating the flap in LASIK surgery. There are some professions that are better suited for surface ablation, like people in the military, people who are prone to eye injuries as well, and where flapation might be an issue. This is a very small subset where you have people with very deep-set eyes or where you have a failed suction on the eye, where surface ablation might come to the rescue. You also might consider surface ablation in cases where you would want to avoid suction on the cornea. Potentially, and there is no evidence for this as yet, potentially patients who have undergone retinal surgery in the past, potentially patients who might have glaucoma as well. But these are just some of the indications for surface ablation. And I think that surface ablation actually is a potential surgery for every patient who is also suitable for LASIK. And let's look at why. Now, this is an example of a patient that we saw about 18 years ago in 2002. If you look at the topography, you'll see that the topography, at least from the eyes of somebody who was seeing it in 2002, looks near normal. The pachymetry is a little on the lower side, but this patient had a low myopia, underwent LASIK with a microkeratome flap of 160 microns, which is what we used to do back in the day, and the surgery was uncomplicated, and the patient did relatively well, had a full correction. But then the patient went overseas and came back to see us about 5 years later. About 5 years later, we started to notice that the cornea was becoming a little ectatic. And this was the beginning of ectasia in a patient where we least expected it. And this potentially is also because of the fact that we did not recognize certain parameters on the topography 18 years ago, which would predispose this patient to ectasia. And potentially 18 years from now, there will be somebody sitting in this spot and saying the same thing about what we're doing now as well. This patient went on to develop full-blown ectasia and 7 years later required collagen cross-linking to prevent further progression. So what I'm trying to get at is there are potentially patients who might have borderline corneal thicknesses, borderline keratometry readings, and these potentially are a very good subset of patients where you could consider surface ablation instead of LASIK. Now, post-LASIK ectasia is not really very common, but we do seem to see a fair number of cases, especially in a hospital that is a referral practice. And post-LASIK ectasia, probably not all of them are reported as yet. And it seems that the majority of them occur in the first year, but there is a significant number that occur later on when the patient recognizes that the vision actually is dropping after surgery. There also have been late cases that have been reported in literature, and we probably will see more of these from patients who were operated in the early 2000s, where the criteria for surgery were a little looser, that lax as compared to what they are right now. But what is important about post-LASIK ectasia and understanding of ectasia and the criteria for patient selection for LASIK is the fact that there are several indices of grading scales that are used now. One of the most popular ones has been the Randleman scale. And if you look at the Randleman scale, even though a patient might not be at risk for ectasia after LASIK surgery, one of the important parameters on the Randleman scale is age. On an average, the age of a patient undergoing LASIK surgery in India and also in the Asian subcontinent is typically a lot lower than the patient undergoing LASIK surgery, say in the US or in Europe. On an average in our clinic, the average age of a patient is 23 years. And this automatically places patients in a higher risk category for developing ectasia after LASIK surgery, though they might not have any other characteristics of being susceptible to ectasia later on. So this also is following the publication of several case reports in patients who've had ectasia following LASIK in one eye, but no ectasia in the eye that had PRK. And this is interesting because it's the same patient with the same kind of risk factors, the same kind of correction, same kind of laser, but then the eye that underwent LASIK developed ectasia, but the eye that underwent PRK did not. That several case reports are similar. This is not saying that LASIK causes ectasia, but just saying that PRK potentially has a lower risk of inducing ectasia in somebody who might be prone to it rather than LASIK surgery. Well, what causes ectasia? In fact, I would say that we probably really do not know right now. There's several hypotheses: eye rubbing, pregnancy, biomechanics, genetics, could be anything. There's only partial evidence right now that points to one or more of all of these factors. And if you look at the literature about which surgery is more susceptible or makes the eye more susceptible to ectasia, the one unifying factor in most published evidence is the association between PRK and ectasia in near normal corneas is extremely low. And that's what makes PRK a good choice for patients who might have borderline topography parameters as well as corneal thicknesses as well. Now, several investigators, and this is an article from Damien Gattiner's group, have investigated performing surface ablation even in patients who have abnormal corneal topography, which normally would not be suitable for LASIK, to expand the indications of surface ablation. And they followed these patients up for 5 years, and they found that these patients were doing really well at the end of 5 years, and none of these patients developed ectasia in the group that they studied. Well, you might say that PRK probably is not as good as LASIK from the perspective of visual outcomes, though it might be better from the perspective of reduced complications. But in fact, the largest meta-analysis that covers the outcomes of PRK and LASIK from the Cochrane database tells us that though the visual recovery of LASIK is faster, eventually in about 6 months' time, PRK and LASIK are absolutely the same from the perspective of visual quality and visual acuity. So this probably also explains the pattern of refractive surgery that we perform at Early Prasad Eye Institute. And this is data from the last 10 years where we performed more than 30,000 refractive surgeries. And if you look at the distribution of how our practice patterns have changed, you'll see that we were predominantly operating LASIK in the beginning of this decade. So we went up to about 70% of surface ablation, and now we're at about 60% of surface ablation amongst all the cases that we do. So the absolute number of cases, as you see, it's about 3,500 cases in a year. And we do a significant number of surface ablation even now compared to the rest of the kinds of refractive surgeries. So we also took time to analyze the outcomes of surface ablation from this subset of patients over the last 10 years to see how these patients are doing. And a significant number of these patients were operated on the WaveLight EX500 system. So if you compare the outcomes of patients who had low myopia between 1 and 3 diopters versus those who had moderate myopia, that is 3 and 6 diopters, you'll see that the outcomes are no different between these two groups. Both groups, 98% of patients were within plus minus 0.5 of refractive error after the surgery at the end of 1 year of follow-up. And you also see that the stability is exceptionally good, and the refractive error really does not change after it achieves stability, say at the end of 1 month or so after PRK. So how high can we go with PRK? Typically, PRK is known as a surgery that is limited to myopes who have a myopia of about 6 diopters. But can we stretch the limits of surface ablation? This is a patient whom we operated a few years ago who had a very high myopia, very high refractive error from the perspective of astigmatism as well. This patient was not suitable for a phakic IOL, and this patient did not want to have a clear lens extraction and was desperate for refractive surgery because she wanted to get married. So we said, okay, fine, we can offer you PRK because the cornea is relatively thin. And we operated her, and now when we see her, it's been about 2.5 years of follow-up for this patient, and she maintains 20 by 20 vision even with this exceptionally high correction and has no visual complaints from the perspective of glare and halos. So PRK can work even in high myopes as well. Typically, the limits that are imposed on PRK are smaller than those that are imposed on LASIK, like we discussed a little earlier. And most surgeons would say that 6 diopters is where they would stop with PRK. And this is why we also looked at literature which says that there are some studies that are published about doing PRK in myopia as high as 12 diopters. And if you compare the outcomes of patients undergoing PRK versus LASIK in patients who have very high myopia, you will see that maybe at the end of 2 years, their LASIK might be slightly better. But at the end of 10 years of follow-up, PRK and LASIK are just about the same, showing that even in high myopes, PRK has a very big role, especially in patients who might not be suitable to undergo LASIK. So we also looked at our data of patients between 6 and 9 diopters of myopia and see how they did against those who had myopia of only 1 to 3 diopters. Interestingly, they seem to do equally well. 97% of patients were within plus minus 0.5 of the intended refractive correction. And again, these patients too had exceptionally good stability at the end of 1 year after the first month of correction as well, showing that PRK or surface ablation does equally well in high myopes as well. So you might ask, why not do a phakic IOL in patients who have this high myopia? Well, there are several reasons, and I'm not trying to justify that PRK should be done for all high myopes, but it's an option for those who are not suitable for other surgeries. And in fact, since cost is a concern as well in a country like India, if you look at the outcomes of a patient who had phakic IOL versus PRK, from published literature, it seems as if at the end of a significant period of follow-up, the mean refractive correction and the mean vision seems to be very similar between PRK and phakic IOLs for the same degree of myopia, which again tells us that PRK has a role even in high myopes, especially for those who might not be suitable for phakic IOL or potentially you might not be able to afford a phakic IOL. So what about topo-guided treatments? Is LASIK better or is PRK better? Well, as of now, we don't have any evidence to tell us which is better than the other. But at least there are a few theoretical advantages of doing surface ablation for topo-guided treatments. One of this is the fact that most of the data that we derive on topography is from the ocular surface. So it makes sense to deliver the treatment onto the ocular surface as well, rather than below a flap, to ensure that you correct whatever you're measuring on the ocular surface too. In addition to that, if you're correcting aberrations in topo-guided treatments, most of the aberrations that you are measuring are on the ocular surface. So it would be prudent to also correct these on the ocular surface and not below the ocular surface, which is what we typically do with LASIK surgery. In addition to that, the epithelium as well as the stroma by itself can mask a number of irregularities from under the surface. And once you take it off, you probably will be able to treat a lot of these irregularities on the surface and thus regularize the epithelium as well, which is another advantage of doing surface ablation using topo-guided treatments. So to conclude or summarize what we learned about doing surface ablations in high myopes, it seems as if from what we observe in the clinic, high myopes take a little longer to recover after PRK is done, and typically visual acuity takes about 3 months or so to stabilize. Though they can do pretty well in 1 month, it takes about 3 months or so for them to become really stable. It also seems that PRK is better with slower lasers and high myopes than faster lasers. And if you're using a laser like the EX500, it makes sense to break the treatment up into little segments and give a second or so gap so the cornea doesn't get overheated with these treatments. And that seems to work as well with the slower laser too. The long-term stability is equivalent to LASIK, and it does not seem to be any different from the outcomes that you could get with LASIK as well. And also, it is a good option for patients who might not be suitable to undergo a phakic IOL implantation. Well, if you look at surface ablation and you ask me why surface ablation is probably a choice, especially in patients who might not be suitable for LASIK, well, it does have its place because eventually LASIK patients whose topography is abnormal might develop ectasia in the future. And there are publications that tell us that even with normal topography and low pachymetry, some patients might be susceptible to developing ectasia, especially the ones who rub their eyes. And because of this, we cannot predict some of the high-risk patients when, how, and why they develop ectasia. And because of this, if you do surface ablation instead in these patients, you do not have to contend with striae, you do not have to contend with any of the interface-related issues with LASIK, and you also probably can sleep a little more peacefully, especially if you're operating on a patient who probably has a higher potential to develop ectasia than LASIK surgery. PRK is also cheaper if you're looking at that aspect of your practice. Eventually, it is more comfortable, except for the first 3 days when patients will call you incessantly about pain. And PRK, I will leave you with this picture, which is a picture of my cornea, which I took about a couple of weeks ago. And this is a picture of my cornea because I have underwent PRK myself for a very high refractive error of -9.5 and 1.5 cylinder. And I'm extremely happy about the outcome of my surgery, and you can see from my picture, there's absolutely no haze. I have a pretty active lifestyle. I play sport, I swim, and I completely appreciate the freedom that PRK has given me, especially since my corneal thickness was borderline and I couldn't get LASIK done. The glasses I wear right now are presbyopic glasses for reading, and that's why you see me with glasses most of the time. Thank you so much for your attention, and I hope you enjoyed this.